Okay, Wendell, in return for getting the honor of batting cleanup, you get to follow Joe. So we welcome back Wendell Primus for the second year. Wendell is Senior Policy Advisor to Democratic Leader Nancy Pelosi, and he has held a number of positions, both longstanding congressional staffer as well as in the administration. And Wendell, boy, you and I go back about 25 years to your Green Book, which was the most famous congressional document, or one of the most famous congressional documents that used to tell us everything we wanted to know about Medicare and other entitlement programs. Wendell. So.
Well, good morning. It is hard to follow Joe. So I have a confession to make. Last year when I was at this conference, I was actually engaged in secret negotiations with my counterpart on the Boehner staff. I think I was optimistic saying we were going to get SGR done, but I couldn't tell you very much. I'm going to tell you a little bit more about that experience in a moment. I guess the second thing I want to say is the title, How Much Collateral Damage? And I think as I go through the speech, it's going to become more clear, because I think our political system has not come to grips with the fact that we're going through the retirement of the baby boom generation. And as you've heard from Bill and James and Keith and others, that is going to have very profound implications for our demographics, for our political system. And I think at some point the Republican Party is going to have to recognize, as Bill Hoagland did, that revenues are going to have to be raised. And Grover Norquist is going to have to be put in his place. And until that's done, you know, the Tea Party is really guiding the Republicans in the House, and I think there's a lot of collateral damage that's being done. So let me begin with just a little bit here. 2015 was a very good legislative year, and I give a lot of credit to John Boehner. He's the one, Charlotte would say, you know, and when he had a staff retreat in early 2015, one of his staffers asked him, what do you want to accomplish this year? And he said, I want to get the SGR done. And then Charlotte realized she had a lot of work to do. And I would also say, and Norm Ornstein, your keynote speaker at lunch, you know, has made this point, it's very partisan in Washington right now. But I think the reason that two staffers were put in a room for 2 months, and basically we didn't do the actual bill. I mean, the actual SGR fix was done on a very multi-committee, bipartisan, transparent process. It was the political part, the paying for it, that's political pain. Anytime you talk about raising someone's taxes or reducing someone's benefit, it becomes difficult, and that's what we were essentially able to do. But so we were able to do an SGR fix. We got a CHIP reauthorization done. We got a budget agreement that eliminated 90% of the sequester, so we actually increased discretionary spending substantially. We got a multi-year transportation deal. We got the XM import big reauthorized over the objections of a lot of Republicans. We got disability insurance that was going to run out at the end of this year. We got that life of that bill, life of that program extended until 2023. And we did $700 billion of permanent tax extenders, also reauthorized the child tax credit. Now, my boss said these provisions should have been paid for, and there were kind of two bills that were happening at the same time. A lot of the Democrats did not support the tax extenders that weren't paid for, but they were supported by Republicans and were signed into law by the president. And the reason, if you remember Joe's slide that says, you know, the new boss, the new speaker is saying, I may not be able to get the budget deal done, 167 of his members voted against that budget deal that got the discretionary caps raised. And that is causing them difficulty right now. Now, the truth is, because it was a 2-year budget deal, we don't need a budget resolution this year. All we have to do is live by the overall spending target for the appropriations process that was agreed to in that legislation that I think passed in October. So we don't need it. And from the Democratic point of view, the Republicans have taken credit for balancing the budget in 8 years or 10 years. And the reason they do that is they have like $5 trillion of entitlement spending that they're reducing. Now, a big bulk of that is the ACA, but there is an $800 billion Medicaid block grant. There's $125 billion of food stamps, savings, et cetera, et cetera. Now, there is no way under the sun that if they actually had to implement the budget agreement that got to zero, they could pass those bills on the House floor. A lot of their own members wouldn't vote for that. And so from a Democratic perspective, we hate the fact that that Republicans get credit for quote-unquote balancing the budget when it doesn't come anywhere close. I mean, the hypocrisy in the Republican budgets are just beyond belief. So here's the timetable on the MedPAC deal, on the SGR fix. So in early February, Boehner and Pelosi quietly agreed they were going to work together. And then Charlotte and I started meeting with CBO staff. We went down a lot of blind alleys. I mean, I really thought I could maybe get at the waste and abuse in the Medicare program in some way, shape, or form, have CBO score it, and that way I could raise some money. And we went down other blind alleys. Charlotte said she needed for her members that we wanted to put an out-of-pocket cap on the Medicare program. That is something that Nancy Pelosi thought would be a good idea. The truth is, as we went through various iterations, we found out we couldn't pay for it, even if we made it effective in 2023 or some out year. We worked for a while, so while I was here, we were actually waiting for some CBO cost estimates on some ideas that we had given them. The truth is, let me flip forward. I would say one thing I did in this whole process, I had to make a phone call in the very last weekend to Doug Elmendorf, basically begging him to give Charlotte something that said this is long-term entitlement reform, and relative to an alternative baseline that I'm not going to get into, it will save a little bit of money. And that's all she needed. Now, the AMA said it was a good deal. I agree with a lot of Joe told you about. Will that actually work? We'll see. It depends. But the point is, the Republicans bought it because it was entitlement reform. The AMA bought it because it got rid of the 21 or 25% cut. And a lot of Democrats and Republicans were also tired of it. Now, in the process, what I wanted to tell you, I gave my boss a lot of grief in this process. And why did I do that? Let me show you. There is something called community health centers and something called the National Health Service Corps. $8 billion over basically a 2-year period. I knew that if those were actually extensions of the ACA. Now, we didn't want to call them extensions of the ACA because then Republicans would vote against them. So actually, Republicans have extended by an overwhelming margin several important provisions of the ACA. And one of it was the community health centers. Now, I also wanted to make sure that that $8 billion of funding didn't go onto the Labor H bill, which is where it would go. And it would further have squeezed other important priorities of the Democratic Party and my boss. However, the Republicans demanded that if we're going to do this in another authorizing bill, the hide language, the language that says you can't perform abortions except in the case of rape, incest, and health of the mother, that had to go on to an authorizing bill. The women's groups drew a line in the sand and said, we do never want hide language on an authorizing bill, only on appropriations bill. And the women members were up at arms. I had shown her the language. It was a cross-reference to the appropriations language. She is a practical legislator, and she was fine with it because she wanted to get it done. But the amount of phone calls and grief that she took for that was quite amazing. The other group I managed to, so the Medicare means testing. Charlotte and I basically suggested to Congress where $72 billion of raisers had to come from. One of them was this, so that's the spending, income-related Medicare premiums, $34 billion. Those are the pay-fors. We got about $15 billion out of hospitals, about $15 billion out of post-acute. But back, so ARP was ballistic for a while until they got calmed down. They did a 180 just before the bill when they realized the votes were going to be there. And we also made various members of Senate Democrats, some of my colleagues on the Senate side, that thought, you know, if you can get a 2-year extension, why can't you get a 4-year extension of CHIP? So I'm just telling you a few of the problems we have as we write legislation. No one believed in early February we were going to get it done. But by mid-March, K Street had woken up, and they realized this was no longer going to happen. It was going to happen. It was going to become a train. And then every lobbyist group came out of town and said, oh, we want our next favorite health provision to write it. It's going to happen. So do something on physician-owned hospitals. And this, again, was a provision in the ACA. It saved a little bit of money. It basically said, to physician-owned hospitals, you couldn't expand unless you got a waiver. And that is a well-funded group. They're primarily Texas hospitals. But they came out of the woodwork and demanded to ride the train. And I knew if they rode the train, this thing that was the hospital, you know, Charlotte and I did our homework. We checked with the various groups, made sure they could support it or would keep their mouth shut, et cetera, et cetera. We knew that the Federation and the HA would go ballistic if we added that to the bill. So I hope that's given you maybe a little insight into how that thing got passed. So I'm going to go quickly here. This is, I think I had the same slide. I went back and looked at my slides from last year. You know, just to illustrate the budget policy golf in Washington right now. Should there be a minimum wage increase? Should there be comprehensive immigration reform, et cetera? And the typical Republican will answer one way, the typical Democrat will answer another way. Here's the president's budget, and I want to just focus on, see if I got that right, those two numbers right there. So over the 10-year period, the subtotal for Medicare, Medicaid, and Social Security is going to go up 1.3 percentage point of GDP. What does that really mean? GDP is roughly 17 trillion, 1% is 170 billion, add a little bit, so you got 210 billion a year more because of those programs. And if I looked at a longer period of time, it's about a 2 to 3 percentage point. And that assumes, as the president's budget, that there's $400 billion of Medicare cuts, roughly. So I'm going to go, these are slides I think every congressperson ought to know. Discretionary spending is down. You've seen that slide in other ways. Productivity is, wages have not kept up with productivity. We have a lot of wage income growth at the top. Income inequality is very high. And there's our demographic bulge that you've also, I think, Keith had that slide. Two factoids: the number of elderly are going to double between 2010 and 2035, from 40 million to 80 million. The percentage of us that are going to be over 65 is going to go up by 50%, from 13% to 20%. So here's the bottom line. We are not going to tweak Social Security, Medicare, and Medicaid enough to overcome that doubling of the number of elderly. There is just no way. So this shows you how important Social Security is to various quintiles of the elderly. These are my factoids that basically say, you know, we're not going to be changing those programs enough. Social Security programs are, the average is about $1,400, $1,500 a month, $16,000 a year. The replacement rates in Social Security have actually fallen. We still have the retirement age to 67 is still going to be phased in. And even for those who believe that the retirement age should be increased, we made that decision in 1983, and it still hasn't completely happened. If we made that decision today or in the next year or two, you wouldn't put that into place until 2050 or something like that. So it's not going to affect any short-term budget issues. You have a program that, you know, if you looked at Medicare by itself right now, you wouldn't say it's a great health insurance policy. Most people have to run out and buy supplemental coverage. Medicaid reimbursement levels are very low. We've actually lowered, according to the trustees' report, Medicare expenditures as a percent of GDP by 2 percentage points. And since 2011, thanks to Grover and others, we've cut spending a lot. So at this point, I think and it's something that not Democrats or Republicans are going to say, revenues are going to have to increase. So I would argue there's lots of collateral damage that has already been done by the Tea Party. Austerity has clearly slowed economic growth. Keith made that point, Doug Elmendorf in a recent paper. Adjusting for inflation, NIH spending, and I get lobbied a lot by all the medical schools that do research. It would have to be $6 billion more in 1 year. Times 10, that's a $60 billion investment in NIH. I think we've underfunded, that's a value judgment, infrastructure, education, research, witness Flint, witness Baltimore, and I don't think we're making enough investments in some of our youth, particularly young minority men, and issues of poverty. So here's the president's budget. I think it's a fairly good budget. And what he's done is he's done investments of, again, over a 10-year period of $900 billion, and those are some of the top lines: infrastructure, mission innovation, is it clean energy research, and things like that. And then he has a whole bunch of tax increases, so that overall he is reducing the deficit by almost $3 trillion. On this chart, and I think you've seen it before, that under the baseline, deficits were going to rise. But under his budget, he's reduced deficits enough so that we stay, the deficit as a percent of GDP stays roughly constant, actually falls for a bit, and therefore the debt held by the public does not explode. Now, if I had to make any advice to the president, I would have said, put some of those tax increases to increase the solvency of Medicare and Social Security. There's the health proposals. So I want to spend a little time on this slide. The truth is that if we solve or make Medicare and Social Security more solvent, we will have taken care of our deficit problem. So we can, if we, again, make Social Security solvent, make Medicare solvent, and actually the president's budget makes Medicare solvent, the HI fund, for 15 years, but really finance Medicare better, our deficit problem goes away. It does mean that spending is going to increase. There's no doubt about it. And revenues are going to increase. And if I had to, this is a health crowd, I've been telling medical providers, ARP and others, that they have really got to raise the drumbeat and beat back Grover Norquist, because without public education about what all the demographics means, I don't think our politicians can make wise decisions. The other thing I would do, and this is not going to happen immediately, I think we need to provide CMS with some tools to fight waste and abuse. Now, there's a lot of tools to fight fraud. And by fraud, you know, if a provider provides services or bills for services and doesn't actually provide them, there are things that can happen to that provider. But there's 3,000 counties in this great country of ours. There's 30 that have home health utilization rates triple the average. There are 5,000 doctors that bill, every time they see a Medicare beneficiary, bill for the highest code, meaning they spend 45 minutes with that elderly person. Now, I do not believe for a moment that 5,000 doctors do that every time they visit or have an office visit with a Medicare recipient. So there are things that I think CMS does not have the tools to go after waste and abuse. So I would give them selective contracting, competitive bidding, reductions in reimbursement, et cetera, that they could only apply to the targeted areas of, you know, they'd have to identify where they think the abuse is and then apply those tools. I would argue we should restructure Medicare to put an out-of-pocket limit, because I think right now Medicare Advantage have built-in advantage relative to fee-for-service. Not that I want to give fee-for-service an advantage, but I do think the reason you see these, besides the subsidy we're giving in Medicare Advantage, the reason Medicare Advantage is going up and up is because it has an inherent advantage. And so why not a public option Medicare Advantage plan? I want something to compete with. I see my panel is laughing at that, but down the road a ways. Prescription drug prices, you know, we are not going to have Medicare negotiation, because with negotiation means the loser, you've got to tell 50 million Medicare beneficiaries you can't have that drug anymore. That's not going to happen. So, yes, I think we need to do things to slow down prescription drug costs. It is one of the fastest growing areas of healthcare expenditures. But there's a real issue here, how we balance costs, how we balance innovation and rewarding innovation, but at the same time, not sticking a huge price on taxpayers for what's happened in our prisons, Medicare, et cetera. And the last thing I would say is I think we need to start addressing the issue of long-term care and improve Medicare's ability. There's been papers written by Karen Davis, Kathy Shane, and others. And I would argue we need a blue state, like Massachusetts did to the ACA, a forerunner that we copied. We need a blue state to provide a social insurance program for long-term care. That way you could offload a lot of the Medicaid expenditures that we currently provide in the nursing home industry, et cetera, and have that funded by a social insurance tax. Now, it will immediately run into the problems we did with the ACA. The least popular part of the ACA was the individual mandate. But to make a social insurance program work, it requires mandatory participation. The health agenda this year, we are going to deal with 2 public health emergencies, Flint and Sika. I hope we do something about the opioid abuse, maybe something on Puerto Rico, maybe a bipartisan mental health bill that would be a lot different than the Murphy bill, because the Murphy bill is not something that Ryan can even pass. It costs billions. Now, they have provisions in the bill that say you can't implement this section if it's not budget neutral. But I'm hoping, and the leader clearly would like to do a bipartisan mental health bill. I couldn't be working for the leader without having a slide that says the ACA is working, and it is working, and it's not. The two things I would say compared to what Joe was complaining, yeah, we haven't kept enrollment up in the exchanges. Well, part of the reason for that is employer coverage hasn't fallen as rapidly as CBO thought it would. And I think the thing you need to look at is how many more people we have insured. And we're probably at 19 million now. There hasn't been an updated number after the recent open enrollment period now has ended in the exchange. But we're probably at another million or so there. If all the states expanded Medicaid, we'd probably add 3 to 4 million. So we are right on target in terms of the predictions, in terms of how much the ACA would have lowered the uninsured rate. I think it's helped constrain budgetary cost, and I think it's also helped, in part, improve hospital quality. I'll take as my reference, I talked yesterday to Mark Larrett, who's head of the UCSF hospital in San Francisco. He says there's no condition that some of the incentives here have lowered hospital-acquired conditions. Hospitals do really focus now more on readmissions than they used to. I see my time is expired. I'll say the conclusion here, I think we need to confront demographic change, and I think you, the public, you, the medical health providers, really need to educate both R's and D's about what all of that means. Thank you.
So we have almost exactly 15 minutes for questions. There are people with microphones on either side of the room. You know the drill. And I can't imagine that with these 4 speakers there weren't some questions raised. We've got a hand up over here. And while the mic. And tell us who you are, please.
Hi, Jenna Jensen from Chalk Children's Hospital. And coming from something Wendell just referenced, which is in order to be able to provide some of the protections like elimination of lifetime limits and annual caps and prohibition against dropping people from insurance when they need it most, that we have this individual mandate in the ACA. And I wanted to ask Mr. Capretta if you could quickly give us a little more information about what your idea is on how to do that without having the individual mandate in place.
Well, first of all, let me just say I don't think the individual mandate, the proof on the individual mandate remains to be seen. We're in very early stages, really, of the law. And if you look at enrollment in the exchanges, the population that's enrolled in it is basically concentrated very heavily at 250% of the poverty line and lower, where the subsidies were maximized. There's a very interesting paper that was done by Mark Pauly and colleagues on the welfare changes, welfare understood broadly, changes associated with the individual mandate, enrollment insurance, and out-of-pocket costs for people who were uninsured prior to enactment of the ACA. And there's a very strong, bright line that is drawn right at 250% of the poverty line. People below that line, in general, not always, in general, are better off in the exchanges and their welfare went up. People who are uninsured and above that line are big welfare losers from the individual mandate or the purchase of insurance, either way. I think that's a reflection on the popularity of the law, frankly. And so what we have recommended is, and so I guess my point there is that I'm not sure that a regime that would come along has to necessarily do anything miraculous, because I'm not sure the individual mandate's doing anything miraculous. There's a lot of people paying the fine. There were 7 in the first 2 years. It's now like 8 million people who are paying the tax, and they're waiving it for scores of millions more. That's another huge underreported story. How many millions of people got waived from the tax? And so it's not at all clear to me that this is some new change in regime that's occurred. I don't think it has. So what we recommend is a proposal that says anyone who stays continuously insured, measured in some reasonable way, would have protections in terms of switching insurance plans that allows them to be assured that their health status won't affect their premiums or the offering of coverage to them, as long as they stayed insured. If someone opted out of the insurance system, then the states would be in charge of setting parameters on what kinds of financial penalties would apply to those people when they want to try to get back in. Okay? Excuse me?
I'm so sorry, but how can you explain to us,
From where?
how is that
Where are you
different?
from?
Mizuho Securities USA, I'm the final speaker tomorrow.
Okay.
How is this, this is really interesting to me. How is this different from a mandate? Because if I heard...
It isn't
you're gonna-
actually that different. Go ahead and
Yeah,
finish the
because
question.
what I heard was we're going to compel people to pay a fine if they don't stay continuously covered, as opposed to what I think the ACA says, which is if you don't buy coverage in some way, shape, or form, you're going to pay a fine. So there's some difference, but I don't think it really is.
It's a difference between the federal government telling everybody that they have to buy something, and then people making using their own personal responsibility, some choice about whether they enroll or not, and then face the consequences associated with it.
Which is exactly what they're doing now, because they can all do math. They're understanding that the penalty
that's
is
not
far
really-
less than the cost of insurance, which is the fundamental problem here. We just saw those slides. You know, I don't know too many people who are making more than $250,000, 250% of federal poverty, who can afford $17,000 a year in coverage for their families. So I guess I'm sorry to interrupt in this way, but
There's a lot more in the plan than just this provision. There is a whole series of financial support for people to get insurance that are outside the employer system. There's Medicaid reform, there's Medicaid reform, there's enrollment and subsidies for going into health savings accounts along with insurance. So the plan has a lot more features than just this. We don't have enough time to talk about it now.
Sure, I'm sure. So does the ACA. Thank you.
Okay. I've got hands over here. Was there anyone else on the left side? Good. Larry, and down front.
Thank you, Murray. Larry Wellickson, used to be a physician. I'm now CEO of the Society of Hospital Medicine, which is involved with our 50,000 hospitalists. And very interesting, so much to talk about. But I would tell you, it's almost like the Democrats threw the ACA out there to distract the Republicans. The ACA is only a play to get more people off being uninsured. And I think the real action is in things like the bundles and all the things that are going to come out of CMS. There's very smart, innovative people that are ready to roll out things. You see how, like, almost overnight, they decided to go into 75 markets and tell the orthopedists that they're now at risk for their total joints. And a comment that came up this morning about what's going to happen to physicians' incomes. Physicians, what I see happening, and I'd like your comments, is that through the way we're changing healthcare payment, we are changing what a hospital is, where their revenue's coming from, and how they perform. They're really becoming much more vertical organizations than horizontal organizations in the outpatient sphere. And physicians shouldn't be worried whether they're going to have what their income is going to be. They should be worried whether they're going to have a job. You know, I think certain specialties like anesthesia may disappear. So there is a move by the way we decide who provides value that is going to redefine what physician work is. And I think that I agree with you. I think this is going to be a year with not a lot of important legislation, but all these new regulations, the bundles, the alternate payment models, will drastically change the landscape of who's valued. And so And I disagree with Mr. Antos every year that Obamacare has been a failure. But
And I didn't say it's a failure. I've just pointed out statistics. In some ways,
We can litigate that over lunch. How about, we have a question down here.
Hi, my name is Ramala Batra. I'm from Scan Health Plan, and we heard a lot about Medicare Advantage, how it's growing. Looks like about 300 plus House members and senators kind of wrote a letter in support of MA and payment. And we are on the eve of advance notice, which comes out tomorrow. And we also saw that 70% of folks are now in 4-star and plus plan, which was an additional bonus or reimbursement. So what is the future hold for MA and 5-star? Is that program going to stay? Same thing, we are talking about chronic care, and so MA has chronic care SNP plans, which have been shown to be of proven value. However, every 2 years they're on the chopping block, and working on the MA side, you cannot create innovative programs if you don't know where the payment's going to be coming from. So what are your comments on that?
So partly that's a question, have we got back sort of the once upon a time MA fee-for-service hostility, and now MA is here to stay? Who would like to? Wendell? Start with you.
Well, MA is definitely here to stay. I don't think there's any doubt. I mean, I'm arguing they have a competitive built-in advantage versus the fee-for-service system, besides the subsidy, the extra subsidy that a lot of the plans get. And as a result, they have ability to coordinate care. We used to pay, when I first came to Congress, Medicare Advantage went the HMOs got reimbursed less than fee-for-service. So there's no doubt, and I know we go through this annual, CMS will put out, and then Congress will react after we get the screens from the Medicare Advantage. I kind of hope that ends at some point, but it's the nature of the beast, I think. I would just say to the gentleman that I do think the ACA we wanted to make an increment in the number of people who were insured. But we were also very concerned about cost and quality, and we put in lots of different provisions. So some of the CMMI, the quality, I used to have a slide that had like 20 different things, and I used to say, these were all things, seeds we planted in the ACA, and then we'll see which ones work and which ones don't. So the issue of, we're going to be at the issues of quality and cost forever. I mean, that's, I think, a safe prediction. And I do think also that the ACA can be improved. I mean, there are clearly things we ought to tweak. I think we ought to provide cost-sharing subsidies a little further up the scale. I think we have some cliffs at 400% of poverty, particularly for 62-year-olds. There are changes that ought to be made. And once we get beyond this election, hoping the right person is elected, I think we'll be able to we can start to improve the ACA.
Somewhere in there was the presumption that the right person is running. I'm going to go to Cindy and then come up to you, sir.
It's hard to follow that one. Cindy Enos, Copal Solutions, and as a former insurance regulator, I frankly, Wendell, have been dismayed by the high cost sharing in the exchange plans. I have said frequently that those were plans I never would have approved as a regulator because of the amount of exposure for consumers. So, and also the co-insurance in prescription drug benefits, again, a huge consumer trap. Balance billing provisions continue, no ban on balance billing in the legislation. I just wondered if there are any serious efforts to correct some of these things that really, really impact consumers' capability of using their coverage.
There's no doubt that we need to make improvements. There's no doubt that we need to make improvements. And, right now, the political system, the House and the Senate are both controlled by Republicans, and they're still fighting. I mean, they're still thinking we need to repeal or repeal and replace. So we haven't had the opportunity to improve. But believe me, Democratic staff are working. There's a very good Commonwealth piece out that talks about the improvements that should be made. So hopefully the political opportunity will be there sometime soon to do some of the things you've talked about.
Would Republicans support any of those since they do impact a lot of?
Well, my Republican friends tell me that once we get by this election, and again, let's assume a Democrat is elected, that then, and I think, I mean, I don't want to test the proposition. I think even with a Republican election, that they will not be able to repeal the ACA. I mean, look at what the governor of Kentucky did. I mean, he did a 180 after he was elected. He is keeping the Medicaid expansion. He may be taking the exchange and giving it over to the feds, which, you know, you think from a Republican perspective, you know, that's kind of an odd thing to be doing, frankly. So again, I don't want to test the proposition, but I think the ACA is also here to stay regardless of who's elected.
Okay, I think we have time for one more question, but I've lost sight of where the microphone's. Sir, you've had your hand up, and I guess somebody else up here. So we'll do one question back here, and if there are other questions, please, we'll take them to the panel over lunch.
All right, good morning. Antoine Harris from DaVita Healthcare Partners. A lot of wealth of information here today. Obviously, you guys are the expert and economists with a lot of data. The one thing for me is you have the same data, but different outcomes and results that has been shared today. And one of the common themes I have heard across all four presentations was aging demographics. Can you offer us anything else that we can take back and be actionable that you align with?
So I
I
hear your
heard
question as
Mr.
you've heard a
Antos ask,
lot
what's
of
the question?
the
I'm really asking,
macroeconomic and
is there a
the
common
larger
theme?
environment.
Is there anything else common among you with the data and the results that you presented today?
Can you agree on anything?
Well, yeah, certainly at a high level, we can agree on many things. It's the details that kill you. I guess one other comment. You're in the private sector. That's where the action has to occur. Don't wait for Washington. You know, you've got a profit and loss statement that you've got to look at, and ought to be a very strong incentive to reconsider how you deliver health care.
I guess the one of the premises of my talk was, at some point, the looming demographics are going to mean we're going to have tax increases. Thus far, the Republican Party has not wanted to say that at all. Now, Bill Hoagland, who was sitting on the first panel, who has impeccable Republican credentials, working for Frist and others, you know, did say it. And I think you can't look at the demographic bulge that we're going to go through without saying taxes are going to increase. Now, I think those taxes can come out of some of the people at the very top of the, you know, that have reaped the benefits of income inequality. Again, there is changing population. It isn't static either, but I think we can increase taxes on the rich without huge economic cost, et cetera. But I think this society is going to have to come to grips with that, because we're enacting a lot of collateral damage by not recognizing what demographics means.
Keith, I hear stomachs
Yeah, I
rumbling.
think we
So
probably all agree that you know, there is a serious demographic and debt problem over the long term that we need to deal with. We all agree that what's happened and what's coming at you probably is much more on the administrative side this year and probably for years to come. That it's highly uncertain what happens in 2017. And I suspect that the models of the 80s and the 90s, where bills were enacted that had, you know, bipartisan combinations of things that worked for everybody, you know, is a good model.
Jim, you want 30 seconds? Okay. Join me in thanking our wonderful panel.